Much for joining today's session, providing diabetes support in your community. My name is Caroline Blanco, and I'm the Director of Program Development and Collaborations at the American Diabetes Association, and we're so excited to have you join today's session. So the topic that we're going to talk about today is really focusing on the prevalence of diabetes and resources and education materials that you can use to help to bring to your community. So if we go to the next slide, over 37 million Americans have diabetes. And so this really shows us the prevalence throughout the United States. So we always like to ask folks to raise their hand if they know somebody with diabetes, whether it's a family member, a friend, folks that you work with, so you can really go around and see how diabetes affects individuals, families, communities as a whole. 1 in 10 Americans have diabetes, and if you go to the next slide, 96 million Americans have pre-diabetes. So the CDC statistics also show on our next slide the continuing increase of rates of diabetes among adults in the US. So you can see this in your county, in your state, in your area. These resources are also available on CDC's website, so you can see how diabetes rates have really increased over the years. And if you go to the next slide, we also see that diabetes is a public health crisis. Minority and ethnic communities have higher rates of diabetes compared to non-Hispanic whites. We know that 14% of American Indians, Alaskan Natives have diabetes, 12% of non-Hispanic Black, 11.8% of Hispanics, 9.5% of Asian Americans, and 7.4% of non-Hispanic whites. So the ethnic minority populations have 50% more likely to be diagnosed with diabetes. So the American Diabetes Association develops our standards of medical care in diabetes, and we really serve as the trusted authority in diabetes care and education. Our evidence-based standards of care help to guide providers, diabetes care and education specialists, and diabetes care team around the United States and the world. One thing that we do want to really highlight and showcase the importance is the notice of community health workers within our diabetes care team. Our standards of care highlights the importance of CHWs as being part of a cost-effective, evidence-based strategy to improve the management of diabetes and cardiovascular disease risk factors, especially in underserved communities and healthcare systems. So to all our CHWs that are on today's webinar, thank you for all of the work that you're really doing at the community level and working to help bridge the community and clinic linkage. So if we go to the next slide, with the focus of diabetes and heart disease, the American Heart Association, the American Diabetes Association joined forces on the national initiative, No Diabetes by Heart. And this is really focused on reducing cardiovascular death, heart attacks, heart failure, stroke in people living with diabetes, type 2 diabetes. So as part of our No Diabetes by Heart initiative, we awarded over $900,000 in community grants in 2021 to 12 organizations nationwide. So each of these organizations received anywhere from $50,000 to $100,000 to implement diabetes support in the community, especially focusing on underserved communities with ethnic minority communities, populations, so that way we can provide diabetes education and support in those areas. So if we go to the next slide, you can see the list of all of our 12 organizations that were funded as part of our community grants. We're going to be focusing today on our collaboration with Gateway Community Health Centers. So we have a great team here that's going to talk through how they implemented diabetes support in their community in Texas. So if we go to the next slide, you can see that as part of our health lesson resources through No Diabetes by Heart, we provided health education resources as part of a PowerPoint presentation in English and Spanish. And if you keep clicking, we also provided videos. Ambassadors provided their testimonials as well. And we tried to offer all of these resources in English and Spanish. And on the next slide, you can see that we also developed patient education resources specific for those individuals to use when they're with their doctors, when they're with their providers, when they're with their health educators, to really talk through what are some questions that they could ask their providers or their educators? How can they help to track their numbers? And we provided these resources in English and Spanish. And on the next slide, we also provided some ADA resources that are specific to diabetes meal planning, healthy recipes, diabetes-friendly recipes. We also have our monthly Ask the Experts. This is our call in or listen in on the computer, where we have subject matter experts going over various topics focused on diabetes to provide diabetes support. So those were also offered where folks could call in or you could listen in online. We also have our Living with Type 2 Diabetes program, and these are resources as well that individuals receive electronically. These are also available in English and Spanish. And as you can see from this healthy plate, we really tried to provide culturally relevant healthy recipes and resources for communities. So if you go to the next slide, this is a perfect example of how Gateway brought these resources to their community through their community grant, how their CHWs, promotoras, their health educators, their registered dietitians, diabetes care and education specialists, really integrated it as part of their community with activities. So if you go to the next slide, this just shows and encompasses all 12 organizations reached throughout the United States. So we're really excited to be able to work across states as well through our community grants. So in total, our community grants reached over 15,000 participants. And then if you go to the next slide, you can see that predominantly it was CHWs that were delivering the health education and the diabetes support at the community level. But we also saw that we had registered dietitians, diabetes care and education specialists, nurses, extension agents, partnerships through local churches and communities. So there was a really great organic grassroots collaboration as part of our community grants process. And if you go to the next slide, you can also see that we were really working with the Hispanic, Latino, Black, African American communities. And then you can also see that the education of the participants that enrolled in these diabetes support programs were either high school graduation or some high school or less. So really looking at that health literacy level and working with the community members there. We also had a population that was 46 and older. And so we were working with various age ranges too. So in the next slide, you can see we had such great positive results. 94% reported that after receiving the health education information and resources that they would be connecting with their healthcare provider to talk about their risk of heart disease with their diabetes, and looking at ways to make healthy, positive changes within their lifestyles. So if you go to the next slide, you can also see that participants reported that they would be taking their medications as prescribed, monitoring their blood glucose, blood sugar levels, trying to be more active, following a heart-healthy diet. So really positive results after receiving diabetes education and support through their community grants. And if we go to the next slide, and this is just one of our highlights. There were so many from the thousands of individuals that participated in the program, but I wanted to highlight one of our participants from the Gateway program. You can really see that her A1C, not only did she make positive lifestyle changes, but her A1C levels significantly decreased from 12% to 6%, and that she was so grateful for participating in the diabetes course that she would refer others to the course as well. So with that, we wanted to thank all of our community grantees, all of the participants that participated in our program, and know that all of these ADA resources, patient education materials, No Diabetes by Heart resources are available through the American Diabetes Association, and we're more than happy to share those resources with you. So I'm going to go ahead and turn it over to Otila, who's with Gateway Community Health Center, and she's going to provide additional information about the great work that they're doing.
Thank you, Caroline. Good afternoon to everybody. Buenas tardes a todos. It's a pleasure for me to be here and share our experiences and some of our knowledge that we acquired through the years. We have been working on diabetes cell management since 1999. We have 21 years of working with people diagnosed with diabetes and trying to support them. So it's my pleasure to share with you we have been doing through those years. And at any time, I think at the end of the presentation, there's a section of questions and answers. So if you have any questions, we can definitely provide you with more information. Can we continue to the next slide, please? Okay, Get the Community Health Center. Can we go back a little at that one? Thank you so much. Get the Community Health Center is a federal qualified health center. We provide services to 3 counties, which is Webb County, Zapata, and Jim Hope counties. We are located at the border with we're in Laredo, Texas, and we're located in the border, which are the border with Nuevo Laredo, Mexico. So our population is mainly Hispanic. 97% of the population here in Laredo is Hispanic, and we also serve Zapata and Hebron, Texas, which are rural communities. So the majority of the services that we provide are bilingual. I mean, we have to take into consideration their cultural beliefs and behavior. So Gateway is located on those areas where the need for medical resources and education and preventive efforts are more needed. We can continue to the next one, please. Okay. Like I mentioned before, we provide services that include primary and preventive medical care, primary and preventive dental care, primary behavioral health care, pharmacy, laboratory, and I can include on that the support services. The support services are like health education. We have different programs to address the prevention of cancer, the drug assistance programs. We have a range of array of different programs that provide support to those patients that are in need, and we help them to navigate to the system in order to obtain those services and that support. Through the presentation, I'm gonna be showcasing some of the pictures that we have from some of the classes, the diabetes cell management classes that we conduct. And as you can see during our sessions, trying to guide the patients and how they can control their disease, we have different interactive activities. So this is one of the groups that were participating some years ago, because remember, we have 21 years offering the services. Can we continue to the next one, please? Okay. We have a program, and we name it the Gateway Diabetes and Cardiovascular Disease Cell Management Program. Like I mentioned before, through that program, we are taking into consideration the cultural aspects. And at this time, we're also taking into consideration the social determinants of health. This is a new approach. We are administering a questionnaire in order to address those needs that the patients have, of course, besides the medical needs and the behavior, the mental health services that they need, but also the housing, sometimes they need work, a job, I'm sorry. Sometimes they need to be connected to another agency that provides some social services. So now we're integrating that to our program. This is another activity where we talk about, in which we talk about positive and negative thoughts. And the patients engage in that activity very frequently. They share their emotions, and it's also a way to offer sometimes a type of support, a peer support to them. Can we go to the next one, please? The program goals. The main program goals are increase awareness of diabetes, cardiovascular disease, now also pre-diabetes, obesity, and depression. By partnering with the American Diabetes Association last year to the program of Diabetes by Heart, we have been able not only to educate the patients of Gateway, but also to go to the community and share the information and educate them in the prevention of diabetes or management of diabetes, and the importance of obesity, to manage their weight, and also to be more active. Another goal is to improve diabetes clinical care to adherence to national guidelines. At Gateway, we follow the American Diabetes Association standards of care. So we are always updating the different guides that we use to teach the patients, and also the providers are following the guidelines. The third one is to demonstrate behavioral change and self-management skills. Through the program, we also share with the patients the problem-solving technique, the goal-setting technique, and we practice those techniques through the whole course, which is a 10-week course. That way they can develop those abilities and skills, and they can implement also those things, not only in regards to their health, but also in other areas in their life, like the personal area or professional. The fourth one is to achieve high satisfaction with care received. By offering this type of services, the patients feel more comfortable coming to the clinic to receive the service from the healthcare provider, or to come in to get the lab test done, because now they know that it's a reason for them to have a lab test. And another way that we have been working with the patients now, they share the satisfaction and they're educating other patients. Sometimes I find that while they're waiting in the waiting areas, they start sharing the information that they learned through the program. And they are motivating some other patients to also be proactive and take care of their health. Can we go to the next one, please? Now, Carolyn was mentioning the community health workers or promotores de salud at the beginning, how we integrate those services and that concept into a Gateway's approach. And honestly, when we decide to integrate the community health workers as part of the diabetes healthcare team, it was based on the cost effectiveness of this concept. Okay, so in the need. So we start by providing training to them. We have a guide that has to be approved by the healthcare providers, our chief medical officer, right now by the dietitian, and we follow those protocols. So with that, the role of community health workers has been to support adherence with providers' management plan, to meet with individuals and families, to offer health education and social support, to conduct a class session on diabetes. And this can be in a group setting or a one-to-one setting, depending on the need of the patient. Provides education that is culturally sensitive and appropriate literacy level. Sometimes we have in our class people in our classes, some participants, they have a degree that they're sometimes they're engineers, they are teachers, nurses, but we also have a person that don't know how to write or read. So we adapt to the needs of those participants. Encourage healthy lifestyle activities and promote self-management. Again, we guide the participants through the process where they can develop new abilities, new skills like the problem solving, like to be proactive, the communication and organization. So there's different skills and abilities that they develop through the course, through the classes. Monitor patient accomplishment, documents and the EHR, collects data and follow-ups. Now, like about 5-6 years ago, we take another step. And now the community health workers are documenting in the electronic health record. By doing that, we are improving in the communication that a community health worker and provider has. Even when the patient is referred to the nutritionist or to the certified diabetes educator, which is Ms. Benavides, which is our dietitian, they are able to see if those patients already receive home education. So they are expanding the education that we provide on an individual basis. Also refers to appropriate community resources. Like I mentioned before, we guide them, we help them to navigate the whole system and connect them, then, based on their needs with the resources available, and facilitate support groups. We encountered this situation since the beginning. When we complete the program, there were some, about 50% of the participants were asking about what is gonna be happening now. We would like to continue with that support because for them it was a support group also. So we decided to offer a support group in a bi-weekly basis. So, and sometimes they need more support, more in an individual basis, so they can contact the promotor de salud or community health worker, and they are willing to talk to those patients if they need it. Can we continue to the next one, please? Okay, this is a graph about the integration of community health workers in our primary care practices. Years and years ago, the model the Gateway had established was first the patient comes to see the provider, and they have the appointment, the provider assess the patient, and then the same provider offer them with some education. It can be verbal, it can be literature that they just provide. After we decide to integrate the community health workers into that model, then they start referring, as part of the treatment plan for the patients, they start referring those patients to receive health education. And like I mentioned before, through that health education, to those sessions, we provide in one-to-one sessions, or it can be in a group setting. Right now, we're following 3 different curriculums: the diabetes and cardiovascular disease self-management curriculum, the substance use disorder and pain management, and the children weight management. Can we continue with the next one, please? That model was changed again when Ms. Benavides, Marisa Benavides, she's gonna be sharing also some information with you after me, as they become part of the team. Before, we didn't have a registered dietitian in our team. So now we're very grateful that we have one. And now the provider, we initiate with the same process. It's the appointment, the assessment, the education that sometimes the healthcare providers offer to the patient. But now, as part of the treatment plan, they also refer first to the registered dietitian, and Ms. Marisa Benavides, the dietitian, refer also to the health education department, depending on the patient's needs. It's mainly, unfortunately, but it's mainly diabetes and cardiovascular diseases or condition. The reason why the dietitian is referring to our program. Can we continue with the next one? Okay, through this integration, there's a lot of benefits. And I would like to list some of them. So to the patients, they say, okay, we were able to collect data and to prove that there was some health outcomes, positive health outcomes for the patients. They receive an individualized care, greater adherence, that they're coming to see the provider, they're coming to get the lab tests done or any other exam that the doctor recommend, okay? To improve access to care, improve quality of care, and the specific needs made by the patients and also the providers. Now, from the provider's perspective, they are using their time in a more efficient way, improve health control. They reinforce the treatment plan because by sending or by referring the patients to the health education department, we are supporting them in regards to the treatment plan that they recommend. It's an extension of the medical services, improve quality of care, they implement clinical protocols, and of course, they help advocate additional clinic services and refers identified. Can we continue with the next one, please? The key successes of the integration or do integration was like to open a frequent communication. Before that integration is, we were working like in silos. Each one was working in their own project, but there was not frequent communication. Now we increase that, the communication is more quality on that. It's the wide organization acceptance of promotores de salud, CHWs. I'm not gonna lie, I'm not gonna say that this was very easy. No, it takes a process. When at the beginning we initiate working with the promotores de salud, CHWs, it was kind of a resistance to accept those community health workers. But after the providers start seeing the outcomes to the patient's clinical data, they start changing their mind. And now they're very welcome to work with the healthcare providers. And then the regular status meetings to assess progress and identify issues, extensive training for promotores de salud, CHWs. Okay. The promotores de salud or CHWs always receiving training. And actually, Ms. Marisa Benavides, she provides also training through the year in order for them to have the most updated information in regards to the management of diabetes and cardiovascular diseases. The documentation that I mentioned before, management support, and this also provider involvement. The providers are referring patients to our program. They are supporting our program. So that is key. It is very important in order to succeed in doing the integration. They regularly assess patient satisfaction and feedback. When we talk with the patients, after they complete their program, we always ask them to be honest and to give us feedback. What they would like for us to improve or to add to the program. And since through the different sessions they have been attending, we establish a relationship with them. They'll feel comfortable to share the thoughts, and they provide us with the tools to improve our program. Can we continue to the next one, please? This is some of the information in regard to clinical information in regards to prove that the program is an evidence-based program. We have been collecting data from several years, but this is the last one, 2021. And one of the goals was to reduce the percentage of patients they have a 9% or greater number in regards to the A1C to lower below 34%. And at that time, we have a 28%. So we achieved the goal. And with regards to hypertension control is to ensure that the proportion of hypertension adults whose blood pressure is under control, and to have it under the 75 Medicaid percentile, and the outcome for us was 64%. The results, it was based on a total sample of 1,095 patients diagnosed with diabetes that participated in the program, and 20% of them, of the 1,095, had a A1C higher than 9, which is 231 patients. And in regards to the hypertension, the total sample was 934 participants. Can we continue with the next one, please? And in order to provide our promotores de salud or community health workers with the training that they need, Gateway decided also years ago, but 15 years ago, decided to become a training site. That way, we can provide the staff members with the training that they need. We don't have to be paying for those, for that training to other organizations, or to start looking for more training, because we can provide it to them. I'm a certified community health worker instructor, and Gateway is a training site, a certified training site with the state of Texas. So that way we are providing staff with the training that they need in order to support our patients. Can we continue, please? And with that, it was the last slide. Thank you so much, and it's my pleasure to now introduce Marisa Benavides, and she has been very instrumental, very supportive of our program. I'm sure Marisa is going to share more information in regards to the integration. Thank you.
Well, thank you for inviting me, and I'm so happy to discuss how our diabetes care team collaborates. Next slide. As Attila mentioned, Gateway's health promoters have been offering classes for more than 20 years, and I've been privileged to work with them for the last 4.5 years. But before I begin my presentation, I want to share what work was like for me during the pandemic. It was pretty tough, and I'm sure some of you can relate. Life as we knew it changed. But at our clinic, all our classes had come to a sudden halt. We had no idea what to expect. You know, our health educators were diverted to other roles, and it was left up to me and one nutritionist to carry the responsibility of providing all the education and support needs for our 5,000 diabetes patients, one at a time. And I think we all thought it would eventually go back to normal after a few weeks, but we know that that wasn't the case. And so for me, that time was very stressful, and I was very overwhelmed, and I was acutely aware of how inadequate I was. So thank goodness, after a few months, Attila was able to roll out our virtual platform and get our education back on track. And seriously, not a moment too soon, because I was really ready to lose it. It was very overwhelming. But at the end of the day, you know, together we can accomplish so much more. And I'm sure you've heard the saying, you don't know what you have until it's gone. Well, I think I always appreciated our promotoras, but after this experience, my appreciation grew to another level. So I really want to give a huge shout out to our health educators and all the health educators out there. Their role is vital to our mission, and for caring for our patients is truly a team effort. Next slide. So today I'd like to discuss the importance of the diabetes care team, and especially focus on the role of the certified diabetes care and education specialist. and the advocacy that we do. I'm also going to review a few of the diabetes self-management education and support standards that are required for program recognition, and highlight how they support and promote ongoing collaboration and teamwork. Next slide. So why do we need to work as a team? Well, aside from preventing insanity and burnout, there is good evidence that it promotes better A1C outcomes. As you can see, when it's provided by a team versus a single individual, there's better improvements. Next slide. Let's see. I just want to, actually, you know what, let me skip this slide and go to the next one first. So I'd like to share my role on the team as a certified diabetes care and education specialist. Many of you may be more familiar with the term CDE or a certified diabetes educator, but about 2 or 3 years ago, the governing board that oversees our credentialing decided that CDE was too limiting and did not fully depict what we do. And many in our field were doing so much more than education. They were advocating, creating policies, working to improve HEDIS outcomes, implementing new technologies, and so on. So we needed to modernize our name, and as a member, I actually got to vote on it. We rebranded ourselves as Certified Diabetes Care and Education Specialists. And I have to say that I think it's a mouthful. It took me a long time to get used to that term, but I have come to appreciate the new title, and I'm so grateful for it. Being a CDCES, it actually gives me permission and has empowered me to get involved in anything diabetes related in my clinic. Because after all, I am the diabetes expert, and I'm the only CDCES in my clinic. So if I don't get involved, then who? So I really feel like having this credential also gives me credibility with administration and the rest of the healthcare team when I am advocating for change. And it's been a very crucial support for me in my role to have this credential. So I'd like to go back to that previous slide. So basically, I just want to highlight a couple of things here. Integration of therapy and coordination of care are key guiding principles to DSMES. And this is where teamwork is especially crucial. You know, recommending additional referrals as needed to behavioral therapy, and especially after the pandemic, I've been doing a lot more of that lately. Medication management, we've implemented insulin titration protocols. And again, I do that quite a bit as well with coordinating with the providers. Ensuring collaborative care and coordination with treatment goals, and then use of performance data to identify opportunities to improvement. That is where, you know, the whole clinic comes together as a team to help improve outcomes. So, okay, I'm going to skip on to the next slide. There you go, thank you. And I just want to mention here, unlike medical nutrition therapy, which can only be provided by a registered dietitian, diabetes self-management training should be provided by a team of clinicians as well as peer health educators. Next slide. Gateway's DSMES program achieved recognition by the American Diabetes Association in November of 2018. And the standards needed to achieve accreditation or recognition also ensure teamwork. And I'm going to focus on standard number 5, the education and support team. At Gateway, the nutritionists and I will primarily focus on one-to-one counseling, where our health educators will primarily focus on group counseling and outreach, especially for those who are struggling to reach their outcome goals. We also conduct several meetings annually for training and updates, as Attila mentioned, and I will sit in on some of the classes from time to time. And this is all to ensure that we're all messaging consistent and sound information. Next slide. Standard 6 states that we must have a periodic review of our curriculum. So an example of how we work together in this area is, I noticed I was spending way too much time in my one-to-one sessions teaching about the progression of the disease and helping patients understand why they need to take their medications. And so when I review the curriculum, I made some adjustments to ensure that our health educators can help with this topic in their groups, in their group sessions, so that I didn't have to spend so much time talking about this one-to-one and teaching this on my own. On the other side, our health educators also have input in the curriculum. So for example, at one of our meetings, they shared that patients are frequently asking about a new diet, or one of them was like, oh, dandelion tea keeps coming up. And so I said, okay, well, let me include some information in the curriculum to help you address these concerns that are brought up over and over again, so that you feel more confident talking about these things and addressing them. And this is how we work to help each other out. It is a two-way street working on this curriculum, and it's an ongoing periodic review. Next slide. And quality improvement is also a team effort. And an example is our health promoters transition to documenting in the electronic health record. And this helps me and our healthcare providers see how well the patients are participating and know what's going on. So before, patients might have attended 10, 15, 20 classes and we had no idea, but now we know, and it really does help the way we address that patient when we see them at the visit. Patient that's coming to classes is an adherent, compliant patient. So the conversation is very different when we know that they're participating. And another project was to decrease the number of patients missing lab values for A1C. This was affecting funding for some of our grant program, but it also affects our UDS and HEDIS measures. So this is a team-wide, clinic-wide quality improvement project that we worked on. Next slide. So the same team philosophy that we apply in our DSMES program is applied clinic-wide to help us improve our UDS outcomes. We not only participate in the No Diabetes by Heart initiative that Ms. Blanco mentioned earlier, but we also participate as a clinic on the other end with submitting data. There's the target BP, check change control cholesterol, and target type 2 diabetes that is sponsored by the American Heart Association and the American Diabetes Association. And we submit data to them as well, and we're tracking our outcomes. And so when I first joined Gateway in January of 2018, our DSMES program actually received recognition from the American Diabetes Association in November of 2018. December of that year, 37% of our patients had uncontrolled diabetes. Now, Otila has numbers that show much better outcomes, but those are patients participating in the program. So obviously patients that are getting education do much better than patients that are not. And so there's a discrepancy there with our numbers, but that's the reason. So I'm reporting here clinic-wide numbers. But it takes a full team effort to tackle the institutional barriers our patients face every single day. And every year since we started tracking this and working on this as a team, we have seen improvements to our A1C outcome. And even last year, a pandemic year, we actually saw a 1.5% improvement. And so clinic-wide, we have created quality improvement projects to tackle all sorts of areas that make managing diabetes difficult for our patients. Next slide. So for example, this was a project that we worked on trying to reduce hypoglycemia in the clinic. As I'm doing the assessments, a lot of times I do the assessments and then I refer to education. But as I'm doing the assessments, it seemed like there was an alarming number of hypoglycemia incidences I was reporting and recording. And so trying to address that required teamwork with our pharmacy and our medical team as well, to help improve maybe our formulary and decrease use of prescriptions and sulfonylureas. And that is a project that also helped improve outcomes indirectly. Next slide. So these are just some of the different things that we've done in our clinic. We've implemented standing delegation orders for our MOAs to streamline that, and to ensure that every single patient that comes in for diabetes gets the same quality of care as the next. The insulin self-titration protocols, again, to help reduce the incidence of hypoglycemia and to increase our A1C or improve our A1C outcomes so that patients can get to goal sooner. And we have implemented protocols for our providers for better management of uncontrolled diabetes. And we've also implemented protocols for pre-diabetes as well. This has helped our health educators as well, because they track results. And a lot of times, you know, we were missing A1C outcomes. And so it wasn't that the patients were doing badly, it's just we didn't have results. And so we needed to have protocols in place to ensure that the results, the labs were being tested appropriately and in a timely manner. Next slide. So this is just an example of the policy that was implemented that, you know, we worked together with our medical team to put together so that we could help patients achieve their goals in a safe and timely way. And this is an example of our basal insulin titration protocol, excuse me. Next slide. Some of the different QI projects. Again, all these projects are team-based. One person cannot accomplish any of these projects. For example, we had patients in our Zapata clinic having to drive to Laredo to access our drug assistance program. And these are patients that need assistance with their medication. So they obviously don't have a lot of money. And so that didn't make a lot of sense. They weren't utilizing the service because driving to Laredo, an hour is gas, time off work, it wasn't happening. And so we implemented a virtual appointment to help, you know, patients from our satellite clinics be able to access this program. And then again, patients that can't afford their drugs are more likely to take them. Another that I already mentioned was having our health educators implement a little more focus on the natural progression of the disease and the need for advancing medication therapy. And so that patients were less reluctant when the time came to start the next medication or to start insulin. Point of care testing was also implemented, you know, as a federally funded healthcare facility. We have patients that are come in and out, and so not having A1C results really did hurt our outcome measures. When we first started tracking this, we had 5,000 patients with diabetes that we serve annually, and 500 of them didn't even have an A1C in the medical record. And so we needed to fix this. That's 10% of our patients, and that really does affect our outcomes. Next slide. Within our DSMES program, we've made a lot of improvements over the last year. We're now offering year-round classes, DSMES classes. We implemented Zoom classes, tech support between classes, decreased the wait time, and initiated a Facebook page support program. Next slide. And so this is just a little flyer. We have our Gateway Diabetes Institute on Facebook. I encourage everybody to look it up, see what we're doing. 2 to 3 messages, maybe 4 messages are added weekly. And it's just a little reminder for our patients on, you know, what are the positive things they should be doing every day to help take care of themselves. So as they're scrolling, and Hispanics tend to be high users of Facebook. So we find that this is a good resource. So it's Gateway Diabetes Institute if you guys care to look for that. Next slide. And then during the pandemic, everything changed. We had years and years of in-person learning, And then all of a sudden we had to transition very quickly to virtual learning. And so creating resources, slides to help supplement the conversation. It's a lot of patient-driven conversation, but having visual aids to kind of reinforce the messaging that we're trying to make on through these classes was important. And our health educators were vital in helping us with the translation aspects, making sure that the information was correct in both English and Spanish. Next slide. And again, trying to figure out ways to have patients direct, or what's the word, have them be more involved in their care. When we had in-person learning, we'd spend an hour on goal setting, and that wasn't really possible in the virtual setting. And so creating questions so patients could, think about how they wanted to make those changes and kind of help them focus on creating goals that would help them achieve whatever it is that we're trying to achieve. And so we created little handouts that we could post while we were talking about, setting self-management goals. Next slide. Here's another example, how to prepare for my next doctor's visit. Next slide. And again, how patients could kind of stop and think about how they wanted to increase their physical activity and create a goal around that. And so there's a little worksheet to kind of break it down into, more tangible steps. Next slide. And again, some more examples. We have so many patients, especially, culturally, that don't like to take medications. And I have a little slide here showing how metformin was discovered in the seeds of the French lilac flower. And so how it's a natural herbal, started as a natural herbal remedy, but by, creating a pharmaceutical grade product, now we ensure that everybody that takes this remedy gets the same amount at the same time. And so creating visual graphics to supplement the education that we're providing in our virtual sessions was something that we worked on a lot last year, and it was a team effort, a lot of back and forth with our health educators and our nutritionist and me as well. And I think that's it.
Great. Thank you so much, Otila and Marisa, for a great overview of the amazing resources that Gateway provides. And also, just to mention, the American Diabetes Association has patient education materials and resources available in English and Spanish. You can visit diabetes.org or call 1-800-DIABETES for more information. Thank you, everyone, for joining today's session. This concludes our webinar portion, and we will follow with questions after the webinar. Thank you for joining.